All right, second live of the day. I've got one of my friends coming on from Canada. His name is Ali Afshar, and when he joins, we're going to talk about what's happening in his neck of the woods in Canada, and also we'll talk about some dentistry. So let's see here. Hello everybody, there he is. Here we go.
Hi, Kyle.
Hey, how's it going?
Good, bud. How are you?
Good.
Nice to see you, man. Hello,
You
everybody.
too. Yeah, thanks for coming on.
Thank you. Thank you for having me. Nice to see you, man.
So why don't you do a quick introduction of, who you are for my followers that don't know you, where you live, your name, what you do.
Sure. My name is Ali Afshar. I'm a dentist in Canada. I live in Edmonton, Alberta. I have a kind of a unique practice. I'm a GP, but similar to Kyle, I think I do mostly implants and implant referral dentistry. So my practice is limited to referrals. I do quite a bit of full mouth reconstructions as well. I'm a Quace guy. I'm a clinical instructor at the Quace Center. And so kind of a unique practice, but kind of in the same page as everybody else these days, not working. We got officially shut down for everything except severe emergencies, so facial trauma,
Right.
severe bleeding, severe infection that's not managed with any kind of medication. So
Yeah.
kind of crazy times for us, I'm sure for everybody who's listening, who's living right now. But
Yeah. When did that start for you guys? When did you get that mandate?
Oh, well, I was in LA actually. I tried to get in touch
That's
with you
right.
about 2 weeks ago. I was doing some training there, and then my college passed that we all had to get quarantined, so I had to cancel my patients. And when I came home, I've been in self-quarantine for 2 weeks.
Yeah.
And last night they upped the mandate. So before we could still do insertions and some treatment like that.
Mm-hmm.
Unfortunately, I wasn't able to go in. So I have a whole bunch of patients that are kind of waiting, it's kind of a difficult situation, but thankfully everybody's been very, very good about it and managing. So we're doing okay,
Good.
Yeah. We're starting challenges, in my house. I spent a lot of time with my kids. I made them watch all the Rocky series.
Oh, nice. Give them the
E.T.
classics.
Yeah, the classics that we grew up with.
Yeah.
I figured they need to watch those kind of things. So we watch a classic movie every night, and we get up, they do homework, we all work out, and then we try to kill each other. And then we have family free time, where we all go in the corners of the house and give each other some space.
Yeah.
It's just funny how things change, right?
Yeah, that's needed. I'm thanking, I'm thanking God that I have a house that allows me to be on the other side of it with, my wife or my son. If we need to do stuff, like you said, we all can have our alone time, and we have a little bit of outside area. So it allows us to still be outside, but not be with everybody else.
Yeah, it's quite cold here in Edmonton still. We're
Doesn't look like it. You got some nice sun or light coming from
about
somewhere.
minus 10 Celsius, so
Oh,
it's
wow.
still chilly.
Yeah.
We going ice fishing this weekend, but
Wow.
but hopefully spring will come here too. Unfortunately, we don't have the.
Yeah, it's different than us. I think it's probably going to be 75 degrees Fahrenheit, and
That's nice.
I'll be exercising outside. So
that's nice. We're still locked in.
I'm glad that we have that opportunity.
Yeah, my man.
So let's talk a little bit about dentistry. I think
good.
you and I practice similarly in the
Correct.
sense that we do this kind of perio-pros
Correct.
practice. Do you think that more people are going to start doing that? Do you think that's like a way that people are moving to this? I was just talking with Mark from South Africa this morning, this super GP, but in a responsible way. What are your ideas around that?
To be honest, I mean, I work with I have 250 plus dentists that refer to me. So I'm very fortunate that way. And what I see is the biggest need for education, especially with the younger graduates, is diagnosis treatment planning.
Exactly.
I think that's what we need to totally focus on going forward. And the creation of these super GPs, people who can kind of do most everything in-house, certainly it creates, it gives the patients an advantage where they don't have to get referred. And, you know, I've lost treatment if I had to refer to ortho, and it takes forever for them to get in to see an orthodontist, and the patient's no longer motivated. Or so having to be able to bring everything in-house and do it at a high level is obviously, I think, would be ideal. That's where multi-facet practices, you know, where you have multiple specialists working in the same practice, same idea. I think to be able to be a super GP, though, education's the name of the game. I mean, you just really have to immerse yourself in quality education, and not just what's available locally. Of course, there could be local education available, but the more you can seek out the greatest educators and go to them and learn from them, and then be able to bring that in to the practice is key. The hardest thing is implementation, right? You can go and learn everything and come back, and if your team's not on board and you're not set up to start implementing and sticking with it, then it's hard to be able to do more and more.
That's a big thing. I think the more education I give, the more I learn that you should bring your team when you can. And I know that's expensive. I know that's hard. I know that can be weird to be traveling with your team. But I think the teams that I see that really excel are the people that bring their treatment coordinator with them, or bring their assistant with them. And then they get to hear it from, you know, the horse's mouth. So like if I'm giving a course, I get to speak directly to the assistant, instead of the doctor trying to then explain something that they just learned to the assistant.
And they're motivated, but they get back and they get the resistance, you know? So of course, if you can bring your team with you, that's critical. We're trying to create opportunities to bring us to the doctor's offices to help implement. Kind of following some of the leads that we've seen with some of the other groups have been doing that. It's the smaller groups, right? But what I've done for a long time is I've tried to have 3 things that I change after I go to every meeting or every continuing education course that I take. And so my staff are prepared for it. When I come back, they know that there'll be some things that change. And I focus only on 3 things. They don't all have to be huge, maybe type of the bond that I use, or it could be big, like changing my entire medical dental history forms. That's something that requires time. But I try to make 3 changes, and I put a 4th one as an optional that I like to get to. And I work towards that. So after 10 courses or 10 different CE courses you've been to, now you've changed 30 to 40 things, and that's a significant change in a practice. You know what I mean? So that's what I've done. That's worked for me, and that's what I would recommend.
I like that. That's a good tip, is pick a few things, go slowly with them, and try to implement them over time. I like that.
Because it's just too hard to come back and revamp everything, right? You fall into your flow, into your groove, and it's just hard to do. So.
Well, I remember when Christian was first giving DSD courses, and they would follow up with people, and they learned something like, it was some very low number. I don't know.
Very low number.
5% of people were actually doing it in practice, and they learned like, okay, we need to have some type of follow up, or we need to make it easier for them, or we need to bring staff, or whatever it is. And that's difficult, because you come back, especially like when DSD was first starting, and I know you got into it early when I did too, is that you come back and you're like, oh my God, I saw this guy talk from Brazil, and he's changing the world, and he's doing this. And the assistants are like, what? You know, we got to take more pictures, or what are we going to do now? Oh, we got to get a scanner, you know? It's difficult because you're like a big hurdle. You're on a high.
It's a big hurdle. Exactly. You're super excited. You spent 3 days, for example, and they're not following it. So, and you know, again, I started collaborating with Christian at the higher level in the last year and a half, and I really wanted to immerse myself in the concept so I fully understand it. So we did the implementation with JJ and Lindy. They came to my office,
Yep.
and really it helped based on what I was coming back. I was already telling them for 2-3 years, this is it. But once the team came in and trained my staff at the same time as me and other dentists in the practice, all of a sudden it was day after we were right rolling into it, which allows to implement things at a different level. And I mean, even it's been a huge difference since that for me, because all I have to say, guys, we're gonna do the DSC protocol for this patient, and that's it. And I'm out of the room, and it just falls into protocol. So it's a lot simpler to be able to.
I think that brings up a good topic, is delegation, right?
Yes.
I think many of us dentists, we like to control everything, and it can be good and bad, right?
Yes.
Because our time is so precious that anything that we really can delegate to someone else, we should, as long as it's being up to the same level. And that is a difficult thing to do. I know.
I think
when I'm teaching guided surgery, one of the biggest things is, like, you know, a lot of times it's to specialists, and they're like, I don't have time to sit and plan all of these cases and this and that. And what I always tell them is, like, find the guy or girl in your office that is always getting in trouble for being on their phone, right? Whoever that is. We all have one of those people,
digitally
right?
savvy one.
Yes. Get them, teach them how to do it. They can bring everything in, right? They can bring in the files, they can bring in the CT scan, they can place the wax up, they can even place the implant digitally, so that all the doctor has to come in and say, okay, let me just move the implant. Okay, let's do the guide, print it, go. And they can be in and out in 5 minutes.
Absolutely. And look, I want to be in control of everything, just like most of us, right?
Like all of us, yeah.
Like all of us, really. And then what happens is I have a hard day and I'm tired and things go on the back burner, and then just end up, for example, not doing something that would have helped me or would have helped the patient. So I think delegation and building a team, a long-term team that trusts in you and believes in you. I always say, when I start seeing my team's parents, family members, then I know they're bought in and they get it. And then that's where I can start delegating things to a new team member. And, you know, my office, everybody has a side delegation, specific thing that belongs to them, that they have to do within the office. So not everybody, not one person gets all of it. Everybody gets a little piece of it.
Right.
And that seems to be effective for us so far anyways. You know?
Yeah, I know, like when we have new assistants, you know, a lot of our assistants place our rubber dams, or at least get them started.
Right.
And sometimes they're really fumbling. And, you know, you want to come in and help them get the concept, but you don't want to just do it for them, because they'll never really learn, right?
Correct.
But then once they get it, I mean, you know, a lot of my assistants are really good at scanning. And I see around the world, when I'm doing courses, you see these assistants that are amazing at scanning, and the doctors can't even do it because the assistants are doing it all day.
I think that's the case in my office now. My assistant, like, I need them to scan everything, really. They're faster, they're more accurate, they're better at it than I am.
It's like if I were to go and do a cleaning right now.
It'd be
not nearly as good as someone who's doing cleaning every day.
Of course, that's key. And that goes with everything else, even with implants and everything else that we do in practice, right?
That's so true.
The more you can focus on what you need to be the best at, then the more you can do it, and then better you become at it. And you can then, I need the stimulation, right? I need to be pushed. So I like to then educate myself and take on more and more, and that's how I've become to be able to do the kind of practice that I have now, just to push. You know, but I need that in my life, so works for me, you know. So
what are like some new, let's say, techniques that you've brought into your practice in the last, I don't know, 1 or 2 years, let's say? That's
so for
been
us,
a big change.
For us, the DSD implementation's been significant. I'm doing quite a lot of it. It's not you know, okay, so I can show you a case. Like, for example, before, the dentistry hasn't changed. You still have to be able to do dentistry. So I would look at a case, and I'll take photos, and I'll analyze it, and I'll pick my point of references, and I use my platform, my articulators to mount the case. and I wax it up, and I try it in the patient's mouth, and then on and on and on and forth. Now what is done is I can present to the patient, we do the test drive, they can see what they like, if they like it, and then from there I have the wax ups already done, and I can just jump right into treatment. So the dentistry hasn't changed, just the mode of the delivery, and I feel like I'm able to drive the treatment outcome versus telling the patient, just trust me, I'm awesome, and this is gonna look good. And maybe you don't deliver on their expectations, right?
Yeah.
So now I can deliver a treatment outcome, which has been amazing. The other thing that we've worked really hard at, I mean, we've set up projects, has been photography. We tried to elevate our photography.
Great.
Just more than just recording, documenting the patient, which what we've done for years, you know, just to work on our light and being able to do better photography, because I do speak and lecture and trying to get better quality photos and try to document a lot of our cases, not just some that I think are exciting, right?
Right.
Just so I have material to teach. Those have been the two big things that we've really worked as a team with my office to do.
Nice.
I invested in a laser, bought a Lanap laser, which is a newer thing, which is a, you know, perio management and periodontal wellness. You've seen me talk on it. It's a big thing for my practice. I created a technique for myself in practice to manage peri-implant disease. And there have been some really cool stuff shown in literature and clinically by people using the laser in conjunction with what I do. It's not one or the other one. I just want to introduce it to what I'm already doing in my practice.
Yeah.
And basically we put the patients in a year program of perio management, which is a chemotherapeutic and mechanical debridement of a patient. And we want to be able to introduce a laser in there for some areas that are more difficult to reach. So that's what's been going on. I'll be excited to share the results with you guys, hopefully when we see where we're at.
Yeah, I think for me, some things that have came in, let's say in the last 2 years, would be partial extraction therapy. This was something that I had seen early on, and then it was really with, you know, our group of friends that I saw people doing amazing things.
And long-term studies with lots of cases.
Yeah, with
how's it been for you in practice?
It's been good. I would love to be able to do it guided. It was something that, you know, I called
because
Christian
it's really a blind procedure, isn't it? A lot of it is you're in the dark. I know what you mean.
It is, yeah. And for me, being like so guided on everything, it's hard to do a somewhat blind procedure like that. But on the cases where I've gotten to leave a shield and have it be the proper thickness and everything, it's pretty wild. Like you don't lose anything.
Right.
It's
so
crazy.
I take quite a bit of pride in building the tissue up, mostly with tissue augmentation in a lot of the cases. So the width, the bulk has just been part of my practice to build in anterior aesthetics.
Yeah.
I've done a bunch of shield partial extraction techniques on papillas in adjacent implant sites, trying to leave it into approximately so I can keep that papilla peak. And I've had some really good results, but I've had some cases that 2, 3, 4 years out, they're starting to expose, you know, where I had to go in, all of a sudden I see a little track line and it freaks you out, and I have to go in and just reduce it down and stuff a little bit.
Yeah.
So the jury's out for me, at least. I'm sure it's my technique, because I've seen guys like Dr. Gartman do just phenomenal stuff that's been out there for a while.
Yeah.
But like you said, if you could create a technique that is reproducible routinely, then that would be really good for those kind of procedures.
Yeah, I think it would be something similar to like what First Fit does, in the sense that if you could have the burr kind of do this and create your shield. But what's weird is you'd have to have one that does like lateral and in depth wise too.
And the thickness wise, because you don't know what the thickness is, right? Like sometimes I'm going super thin, and then you're risking mobilizing that in time, and then all of a sudden you have a sequestrum just moving through the tissue coming out, which can create issues for you, you know. It's a super highly technical procedure, but certainly
Definitely.
in his place, it can be a lifesaver, especially aesthetically.
Yeah.
I play with it a lot. I consider it often.
Yeah, yeah, me too. I definitely, a few years ago, I didn't even consider it.
Mm,
And now I try to consider it on every case,
right,
whether I do it
right,
on every case or not. But
right,
I try to consider it. And the ones that I've had where I've gotten a shield that's the proper thickness, sometimes too thin, sometimes too thick,
right.
um, the response is
Because
really nice.
when it works,
Yeah.
it's phenomenal. There's no
But
question,
it's
and we
very
know
technique
that.
sensitive, like you
Hmm.
said, and I would consider it kind of an expert
Correct.
technique
Without question.
for
Yeah,
sure.
absolutely, absolutely. And with these ailing implant issues that we're having, these are things to consider very carefully.
Yeah,
What I found over the years doing just literature review, because it's funny when you start speaking on its subject, you really want to learn as much about it.
yeah,
It's almost a learning experience, right?
yeah,
That really, for a lot of our peri-implant disease issues, we don't have a proper diagnosis.
no,
We don't know if it's a bone to implant contact, what it was. We don't know if it's a secondary infection. We don't know
yeah,
if it's a foreign body reaction.
right.
We don't know if it was a surgical position a lot of times. So there's multiple things, and we don't have a consistency in definitions of diagnosis. What is peri-implant disease? How do you define it? How much bone loss? Because there's a lot of different variations in literature as how you define that as well, right?
That's definitely true.
So when you start treating something without a diagnosis, that's the first thing I teach. You need to have a clear, concise diagnosis.
Yeah,
Treatment plans can be different. There's many
yep,
different ways of treating a case, but we need a single correct diagnosis, and there's only
that's
one.
right. That's right.
And a
Yeah,
lot of times,
I had a professor in dental school that said there's one diagnosis, right?
yes,
And there could be multiple treatment plans.
and it's Morty Amsterdam said that. I
Hmm.
mean, the great Dr. Amsterdam said that. So a lot of these cases we're treating without really knowing what happened. So I think a lot of the variation in treatment success that we see is because of inadequacy in diagnosis, and
Yeah,
it's just difficult thing to do at this point, right?
yeah, it's a great point. And you brought up tissue grafting.
Yeah.
How often are you doing tissue grafting with implant, whether
Placement.
it's at extraction or during placement or
Yeah.
sometime during the implant workflow? What percentage of your cases are getting tissue grafted?
So anterior cases, I would say my plan is 100% of the time.
Yeah,
Not always it happens. Sometimes the tissue is just amazing and the
right.
width is
You
great,
get
but
super thick tissue
those are
patients.
rare.
Yeah,
So anytime I work in anterior aesthetic zone, let's say, I plan tissue graft.
same with me.
On the great, good to hear. On the
Hmm.
posteriors, depends on attached gingiva and the thickness of the tissue. We know we've seen with the bone height. So I like to have that tissue thick.
Yeah,
And I like to have as little as more immobilized tissue, the better. It might not
yeah,
be straight out keratinized tissue, but
right.
immobilized tissue on the
Yeah,
posterior areas without eliminating the vestibules and stuff like that.
yeah,
So it's a
I'm the
big thing
same
for
way.
me. It's a big, and I build it into the practice, into the implant fee.
Same way.
And
Hmm.
I don't have to have this discussion with the patient that maybe you need it, maybe you don't. I just like to do it for them.
Right. Yeah. This was something that I think I didn't learn early in my career.
Yeah.
I, it's been over the last just maybe 3 years that I've been doing it more and more and more and more. And
Right.
this is always something that I try to advise younger doctors that are getting into, anything in the periopros area
Right.
of implant dentistry is the importance of tissue. And I think so often in the first 40 years of implant dentistry, we only thought about bone, right? It was just
Absolutely.
bone, 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 because we didn't have great osseointegration. We didn't really know if this is going to work. The surfaces weren't as good. The designs of the implants weren't as good. The research wasn't there. And then now, like, we figured that out.
Yes.
You place an implant, it's probably going to integrate. I
Yes.
mean, very rarely does it not. When it does, like you said,
It's
sometimes we
health
don't know.
related or yeah.
Yeah.
Okay.
But now it's like, okay, we've got the bone pretty much taken care of, right? Now we really got to focus on tissue. This is what's going to make it look natural. This is what's going to make patients happy, long-term stability, protecting it from the bone, protecting the oral cavity, the bone from the oral cavity. So that was something that I try to pass on.
And
often.
yeah, I mean, Linkovicius, I know it's right on point with a lot of things, just moving that connection away from the bone as much as possible and giving as much thickness as possible.
Yeah.
Those are key. What I tell young docs who ask me is learn to manage the tissue first. Really, it's a different way of looking at it. Learn to do connective tissue grafting. Learn to do root coverage grafting, because these are the things that teaches you to get good with handling and managing the tissue, tunneling techniques, and start doing that. Because let's say you see someone like Dr. Pat Allen and learn his technique, right? And you can come in and day one you can bring that to the practice, which is an additional procedure that you can do. You can create revenue from it. But let me tell you, those concepts, they go everything you do, just learning how to suture properly, which, you know, making the proper square knots and making sure things don't open and managing tissue, elevating. Then going into the implant training, I think you'll be way ahead of the curve as far as you learn it. And that's not how we were trained, were we? Here's a bone, plug it in. Now the patient has a tooth because they didn't have teeth before, you know. We're just doing a service. Instead of wearing a partial denture, now you have implants. But like you said, those days are long past. And now we need to really do a whole body treatment plan and trying to regenerate the initial contours and function and aesthetics all together at the same time.
We think very much alike on this, because
I like that.
So many times I see people doing these courses where it's like, you know, we're going down to Mexico, we're going down to the Dominican Republic, and we're going to place 20 implants in a weekend, and gosh, I'm going to get all this experience.
Right.
And they come back to their practice and they have all these complications. And I think what I always say is, like, start with theoretical, you know. Get the theoretical behind you. Then you have to make sure that you know how to do, like, surgery in general, right?
Yeah, so you gotta be able to lay flat.
Yeah, see, I've seen people go to these courses, they've never done an impacted wisdom tooth.
Right.
You know, it's like, do you know how to hold a, how to hold a blade, or what angle to place your blade when you're making an incision, how you score tissue.
And we see that too.
How, you know, making a basic flap. And I think a great way to practice this, especially for young doctors, is by doing these kind of partial bony wisdom teeth. You learn how to make a flap, reflect a flap, you know, play with bone a little bit, remove these, but it's not in the aesthetic zone.
Yes.
If, you know, your flap doesn't come together perfectly, it's just going to heal fine anyways. And so it's a very kind of low touch, low risk way of still getting your hands dirty and getting better at surgery. Right.
Without question. For us, we teach a 5-day training course, which on the 5th day, the docs get to bring a patient to our office, and me and my partner, we assist them, right? We sit right next to them. And basically the first 4 days is diagnosing and treatment planning what are simple cases. So non-aesthetic zone, proper attached tissue. These are cases you shouldn't need a scan to know what kind of bone. Wide
away
ridges.
From the nerve, away from the sinus.
Exactly
Big,
right.
wide opening. Right?
Exactly right. So we go through the criteria that they need to do it. Then we help them use those criteria to find patients. And then we approve those patients, and then they get to do a slam dunk implant on those patients, and we help them through the restorative phase. And we feel like that's a good enough start. And then I give them tools. Okay, now you can do tissue courses, or you can do socket preservations, or this and that, and fill up your repertoires of tools that you have to offer to your patients on a day-to-day basis.
I think the hard thing with many GPs is that once they get, you know, they find out, they take a course like yours, they find out what the proper case is, right? They may only get 10 of those a year.
Right.
You know, and this is always hard. And people ask me this, and I don't know if I really have the answer.
I tell the docs that I work with, look, if you're starting to do implants, don't look at it as a way of making more money or because for you to be able to do this, to make money, you have to do a lot of it. So how do you get a lot of it? Either you're a specialist or someone like me who flukily
Has a big
create
referral. Yeah.
big, or you're part of a big practice or multiple group of practices that they can start sending you cases.
Yeah.
Because it doesn't matter how much you train, if you're only doing one, imagine if you're doing 1 or 2 root canals a month, maybe.
Yeah.
You're not going to be doing
You're never
molar
gonna be good at
implants.
it.
You're not
Yeah.
going to, you're just never going to get to that expert level, right?
Yeah.
So if you're doing it because you want to challenge yourself, because you want to,
You're interested in it.
in you want to learn more and maybe create opportunity to move forward. But if the ambition is, I want to make more money, probably the inventory, everything that you have to do to get to that point is going to be a lot more expensive that you're going to gain by placing a few implants.
Yeah.
Now, I don't want to discourage anybody. I'm an implant dentist, but just have the mentality right coming into it, moving forward, right?
Yeah, that's a really good point, because implants are expensive, the burrs are expensive, the motors are expensive, everything's expensive.
Inventory is huge, yeah.
Yeah.
The setup, the tear down, the time that it takes in the clinic. Like, I can place a routine implant in less than 10 minutes.
Yeah.
My team will turn the room around in about 15 minutes. So half an hour is plenty of time for us. And I can place 10 implants in a day on 10 different patients easily. Yep. But that's from years and years and years and years and years. Right. You know what I mean? If you're just going to get 1 or 2 implants, it's just tough. It's just tough.
It's hard to get good at anything. I always relate it back. I mean, just like you said with root canals, or it's like, if you do an all-on-4 once a year, will you ever get good at it?
Yeah.
Maybe if you're very meticulous about everything. But
you're never going to have the flow. It's just going to be. So bringing the all-on-4 up, Kyle, what are your thoughts about how many all-on-4 treatments are we seeing out there these days? And the practices are dedicated to all-on-4, because that's how I see GPs do more and more implants, because they're getting to do all-on-4s. That's a lot of it's going on. So what do you think of that?
I think there's an over treatment of all-on-4s happening.
Right.
Personally, you know, I think that it's become like a treatment in a box, right? It's an easy thing. It's high fees. You know, it's a big change for patients.
It's one thing they can present to the patient, and
yes. I think that in the US, it's gotten to this point of where it's becoming so easy to sell or do that people are doing it that shouldn't be doing it. And you do have, you know, groups, certain groups of offices that are just doing this. And
some are doing
that may be good or
amazing
bad.
Level, right? Yeah.
You don't know, but it's one of those things, like, if you're just doing one thing all day, you're probably going to get pretty damn good at it.
Right.
You know, I mean, depends on how much time you're taking to plan and what materials you're using and so and so. But I guess I think it's a great treatment for when it's indicated.
Yeah.
And it is oftentimes overused.
From what I see is, and honestly, 10, 15 years ago, the mentality was, oh, this tooth has got a root canal or kind of not looking great, take it out, put an implant, implants forever. Well, we know that's just not the case.
Right.
And I'm starting to see this shift in dentistry amongst opinion leaders and really even implant docs is save the teeth when you can.
Yeah.
Save. So that's where super GPs or GPs who are well trained and educated, they have this ability to be able to do a comprehensive treatment plan and replace implants or place implants where they need to, or replace the teeth where they need to with implants, but save the teeth and really, more importantly, save that bone. Because when you cut the bone out, let's say 16, 17 millimeters, to create that space that you need for your prosthetic, and we know what the rate of failure for implant is, really. We do know it's a problem. Hopefully we can deal with it. What will happen is that patient's a cripple if that doesn't work. They're in a really bad place. Yeah. Most of these all-on-4 patients are typically high perio patients, high level of stage 4 periodontal disease. And those are super high risk patients for implants.
For sure.
Even if you're taking all the teeth out, even we're doing oral antibiotic rinses to disinfect the mouth. Those patients, I tell them, you're high risk no matter what I do, no matter how closely we monitor you, no matter
Yeah.
how diligent we are, you're high risk. So we have to be a little bit careful with this
I
mindset
agree.
that people are having, right?
This brings up 2 points. One point is I published an article with some of my friends from Brazil from my residency, and we were looking at peri-implantitis, and we looked at all different kinds of things, how often they got a cleaning, smoking, age, etc. And one of the biggest things was younger patients
Yes.
had more peri-implantitis. And when we saw that, we were like, what the hell? Why would younger patients? They're healthier, you know, they have better manual dexterity, all this stuff. And what we realized is that these people lost their teeth earlier,
Yes.
right? More than likely, these are these perio patients. Or if they're not perio patients, they're patients that don't have good oral hygiene in the first place.
And the habits didn't change. So we just changed the
Exactly.
mode of failure from
Yeah.
teeth to implants. Because,
Right.
I mean, it's the same bacteria, right? We
Yep.
do know that the mode of action may be different. We don't
Right.
fully understand, but it's the red complex. We see a huge spike of those red complexes. And I done some cases that we treated with managing the peri-implant disease, and we did the bacterial test.
Yep.
And I'm pushing 4 years now. They're all stable. Not every case I've treated that way in practice will be stable, but the ones we did for the research, they're all stable, the surgical ones, but not one we've been able to bring the red complex down, really. So the bacterial load's still up.
Still
We've
there.
just been
You
able
just have
to
to control
manage.
it.
Yeah. So if these patients, I feel like if these patients slack or we don't do a good job or a pandemic happens and I can't see them for 3 or 4 months, it'd be really interesting to see what happens when we go back. Hopefully they're keeping up the home care the way we've trained them. But it'd be interesting to see, and I agree. So I want, if anybody's listening, be aware of those all-in-4s. They're not a generalized solution for everybody because we're fixing a lot of them. And another one that I'm seeing is teeth out and implants with locators, especially on the upper arch. A difficult treatment choice because of the angulations. So although locators allow for a certain degree of connection, when you have multiple locators, they create binding. So you actually create less retention, and with not having the cross-arch stability on the maxillary arch, implants get more compromised. That's in the literature. And we have to be very careful. If you're doing locators on the top, I've done them. I do them guided. I sacrifice some AP spread or for accuracy of the perfect parallelism, the 4 implants all the way around. You can take the palate out, but again, I explain to patients that it's a high risk procedure versus something fixed. It's more cost effective, but it's definitely high risk. So that's something that I like to preach as much as I can for people to be careful about.
It reminds me, I just had a patient come in, older lady, I mean, pretty old lady. I think she was probably in her 80s or something, and she had 4 implants on locators, and like 2 of them just basically needed to come out, and she wanted to just try to save this prosthetic, and I just basically had to tell her no. I just had to tell her I can't do it. If you don't want to do what
needs to be done, which is
sorry.
Probably what happened to start with. You know, that art of sway, patients want the least, but I advise to the guys that I work with, they don't remember that conversation once things go sideways, right? They want the cheapest and they want the fastest and they want the, but they also want it to function at the highest level possible. Something's got to give in this equation. You know what I mean? So I like to really over-engineer and under-promise, but I like to meet expectations, and I like to be able to deliver the outcome, like I said, drive the treatment outcome versus hoping for results, right? That's the goal in every patient that I treat.
Yeah, you brought up another good patient is to reducing bone, and then what happens if we have problems, right? And if there's any bone left, it brings me to one of my friends who's down here, an oral surgeon named Human Zerenkelk, and he's kind of the guy, at least from in Noble Biocare, that teaches a lot of people how to do zygomas because he's been doing zygomas forever. And he is just kind of like the save me oral surgeon in Southern California, because he's doing so many, like you said, redos on all on 4s where now there's no more bone and we have to go to the zygoma. And I think I think we're 10 years away from the same problem happening with zygomas now. Is Everybody's
And
learning to do zygomas now.
and the zygoma, the complication level with
And
the
if the
zygomas.
zygoma fails, I mean, where do we can't go any
Yeah,
higher. You know,
right.
we're not going to put it into their eyebrows.
I mean, zygoma is a 4 centimeter long implant that 3 centimeters is in space.
Yeah.
Right, really. I mean, that's
Right.
what it is. I know
Yeah.
that it works, but it's from everything that we learn to be ideal, it's a last stand
Yeah.
treatment for these patients.
Mm-hmm.
So for us to put them to a point that the next level is that, we really have to make sure that is the last option they got. You know what I
Yeah.
mean? I mean,
So true.
I don't know if you play zygomas. I'm not able to deal with the complications.
Yeah.
And my
Yeah.
goal
I
in
don't play
practice has
zygomas. Yeah.
been that if I can't deal with the complications that arises from it, I'm not doing it.
Yeah.
Now, once in a blue moon, maybe something gets funky, but other than that, I like to be able to deal with most of my, so I'm not doing zygomas.
Yeah.
Reminds me, I had a patient that we did a lateral sinus lift, and he came back with the graft in his hand, and I was amazed by it, right? So he was wearing a nose, the cannula CPAP, and it blew it out. Just a point for people who could not believe it. So
Wow.
just be aware, if your patients are on CPAP and you're doing pretty big sinus grafts,
Yeah.
you know, get them off of it.
That's
Just a
good point.
Little point.
So someone asked a question, what is the average age of someone going into zygoma implants post failing all on four? I don't know if there's an average.
I don't think so
I
either.
don't think there's an average case of that. I think that number is going to come down more and more because people are getting into all on fours earlier and earlier.
I agree with you.
And the sad part is you get these patients where they've been struggling with their teeth their whole life, right?
Right.
These are the patients that come into you and say, you know, I've never had good teeth and I've always had deep cleanings and nothing ever happens. My teeth are always loose and they're falling out and they hurt.
Right.
I just want to get rid of them. And they think that that is like
the solution.
The solution. That's it.
Right. And I tell them, you're creating one set of issues for another one.
It's true.
You're never going to get a cavity here, but you're buying a very expensive car and your oil changes are going to cost a lot more than they did before. And you really have to come in for better maintenance and better care, you know. Before you may be driving a Ford, now you're driving a Ferrari. It's a completely different level, right? And we like to deliver that kind of a service to them. So, no, I agree with you. It's but the zygomas, I'm still doing quite a bit of bone regenerations for a lot of those patients. Irvin's technique with even vertical or horizontal, to be able to get the premaxilla fit enough to be able to place implants.
Right.
And I'm having very good success, very predictable with horizontal bone augmentation without question.
Again, another expert treatment that is not easy.
No.
And high complication rate early on.
It's all in the tissue management.
Yeah. Well, that's like going back to what you were talking about is like learning how to raise a flap, learning how to release a flap, getting true primary closure. You know, Isfan always says like he can grab the flap and walk around the room with it, right?
Absolutely right. And he can.
Yeah.
He can. I've seen it.
Yeah.
Yeah.
So, and I was the same way when I, you know, because I trained with Dr. Jovanovic for the last, I guess, almost 9 years.
Right.
And I saw him doing these cases and it looked so easy for him.
Right.
And I knew all the techniques, but when I first started doing them, gosh, my complication rate was high.
And the experience, the experience is you need that experience, which you have to do, but you have to select the cases.
Yep.
You know, so zygomas for me are the patients that are sinuses are unhealthy or smokers, which then I'm not doing grafts on these smokers. So if they're not smoking, I'm doing the augmentation. Then typically I can handle the sinuses. And I can give them enough that I don't have to go on the zygomas.
Yep.
But I see cases that are getting zygomas and lateralization of the nerves. Those are severe cases. That's outside the scope of my practice for sure.
Yeah, same for me. So are you doing any tuberosity tissue grafts like Inaki's style?
Yes, I've been doing that for a long time. I feel like the density of the tuberosity tissue is the best.
Yeah.
And you know, like I do quite a bit of, you know, like alloderm or matrix, but
Yeah.
I like to double them up. But I know I lose about 40% of that volume. So if it's a straightforward anterior case, I'll go to these matrices, and that seems to be plenty good, and I don't have to harvest.
Nice.
But let's say I'm doing a puntic site development on a site that's really highly resorbed. Let's say bridge failed, and I'm replacing 2 implants, but we're still doing a bridge on 2 implants. I like to go to the tuberosity.
Yeah.
But what Inaki's doing, I mean, that's mind blowing.
Yeah.
No comparison
He's a wild
whatsoever.
man.
Yeah, it's just he's a blip outside of the bell curve for everybody. But to me, he's just an artist and a magician, and I just love to learn from him. What he does is truly amazing. But yes, that I've been using that. I take a big loop. Used to use electrosurge, now I have, and I just, if the tuberosity is there with the big loop, you just go take it out. Before I take the tissue out, I de-epithelize with a round burr. It's just
you do
easier.
it before.
It's just easier versus on your bench, which is, so I grab a fat round burr, I just de-epithelize, and then I take that chunk out, and it gives me a really nice fat, and the loop just cauterizes it, and it's done.
Do you do it like Iñaki, where you take like a distal wedge kind of thing?
If I have enough.
Yeah.
Sometimes you don't have enough.
Right, so you have to kind of go lingual.
You go lingual and just try to take as much as you can.
Right.
When you have enough, then that's easy, because then you just suture it and close it, and it's done.
Yeah.
Right.
Yeah, I've really enjoyed doing that. Now, the hardest thing with it that I found is just access.
Yes.
You know?
And the wisdom teeth have to be gone typically, right? Otherwise you don't have it. So
which helps in the US, because most of our patients don't have wisdom teeth. It's just kind of a cultural thing that most people get their wisdom teeth extracted. Yeah, I know that, you know, when I was working in Brazil or in Europe, it's not as common.
Yeah, here is a standard of treatment. We recommend it for most of our teens to have the wisdom teeth out prophylactically, so it doesn't become, unless it's fully erupted and they can keep it clean. Right. We recommend taking it out.
There's space in the jaw. Yeah, we're the same way. I found that these tuberosity grafts are really nice. They do grow over time, which, you know, patients may not like. We love, right?
Yes, without question.
Patients may not like. What I like now is, did you read that new article that was sent in our WhatsApp group that Marcus Blatt sent?
No, but it's my to-do list.
It's on your list, yeah. So really cool that Iñaki is doing circular tissue grafts, meaning like taking a regular tissue graft, but then wrapping it around the provisional of an immediate implant. Yeah, you
without laying it flat, right? Oh, look at it. That's cool.
Yes, yeah.
So I've seen like
cool.
the guys who kind of flay the papilla and then bring the tissue underneath to pump up the papilla, you know?
Right.
So those are cool, but super high-end techniques.
Totally.
I mean, you have to be really careful. I like to, with the tuberosity, I tunnel the papilla and I try to tuck it underneath just to create as much volume as I can when it's a high aesthetic challenge case, which we lost. But like you said, a lot of these are redo cases that I'm doing. Typically implants are too far buckle, and I've lost the quality tissue, so I take it out and I usually do a VIP flap or something. I'll bring the tissue to close where the implant's coming out, just thicken the tissue as much as possible, bone graft, let it heal, come back, place an implant, re-tissue graft at that point. I'll try to play around with the papillas as delicately as possible in those cases.
Now, are you doing, I'm thinking of things that I've kind of incorporated in the last 2 years. Are you doing a lot of molar immediate placement?
I place molar immediates when it's possible. Typically, if the forcation, there's bone in the forcation, I don't hesitate. But I don't also feel like I need to really push it. And, you know, I trained with Megagen like 12 years ago with those trephines that they were doing. It was kind of a cool procedure. What we saw was that the mesiobuccal root of the molars resorb, or the bone over the mesiobuccal root, because that's the thinnest. So if you put in a big monster implant right in, you know, you can get some thread exposures over the years. So if I can position my implant right into that septum in the right position, then definitely. But it's not something that I look for day in and day out. You know what I mean? Does that make sense? Are you doing the same thing?
Yeah, no, for sure. It's the same thing. When I can, I do.
It's just nice to do for the patient, right?
I love it for the patient experience. It's one surgery.
It's finished. Yeah.
You know, one surgery finish, not extraction, bone graft, then next one, implant placement. You know, that may have to be a 1 or 2 stage. Most of the time it's a 1 stage, but you know, sometimes 2 stage. And we're looking at 3 surgeries.
Right.
If you can get it and you can get primary stability, it's 1 surgery. Next time patient comes back in is for final restoration.
Right. And I use the Densiburs. I don't know if you have any experience with them. A lot of these, I like them. I kind of don't use them as the company recommends. I don't care as much about the densification of the bone.
Right.
I use it as an expansion tool.
Yeah.
Right. So displacing the bone versus cutting the bone, especially
the bone,
when I have a little bone. So in anteriors, all the time, I like to small with a 1.5 millimeter drill and just expand.
Yeah.
And that's worked really well for me. So a lot of times I finish with my final implant drill, which is not what they recommend because I take that densification zone out.
Yeah.
But I've had great success with it, and I use those drills when I'm doing these immediate molars because I'm not moving anything. I'm just displacing the bone and then just graft it and place the implant.
Yeah, no, I think that's really good. We've got about 5 minutes left.
Okay.
Any other techniques you want to talk about?
Any
Hey, Jack's on. If you guys don't know Jack Goldberg practices in Mexico with Ricardo Matrani. You know, probably one of the top teams in Mexico. So
definitely, without a question.
Definitely check out Jack. They have a great article that they came out with, I don't know if it was a year or 2 ago, about where the lip plays in relation to full arch treatment. So Jackson Acapulco. Oh, come on, Jack. Don't tell me that.
Tough life to quarantine in Mexico, hey, my friend?
Yeah, it's a really good article that him and Ricardo did.
Yeah.
Would you place an implant in a palatal root space after molar extraction?
Maxilla?
Yeah, I wouldn't. And I've seen that before, and I've had to fix cases like that. It just, when you put the implant not in the right position, you're always behind the 8 ball. You know, you're always trying to make up for it. And I think one thing you really got to focus on is putting the implant in the correct position based on the final tooth, wherever that may be.
Restoratively driven, right?
Yeah.
Right. I agree. Like palatal, you're typically fighting the sinus anyway, so your primary stability is going to be an issue. Usually, if I do it in the molar, sinuses, upper maxillary molars, sinuses are far away, and I have a nice trifurcation of the roots.
Yeah, so, something like this, waiting for you to.
So maybe I'll position the implant more palatally, but not into the palatal root typically.
Yeah.
You know?
Can you talk about learning curve of simple bone grafting and implants for GP? Yeah, go ahead.
I mean, it's a tough one, right? Because it takes a lot of time between the first few cases. So you're going to take a case, you do a bone grafting, you got to wait 4 months or 3 months, whatever your protocol is to go in, and then place the implant, then you got to wait a couple of months for it to heal, then restore it, then follow up with it. So it's going to take you a year to see a case through. Whereas if you're taking an impacted wisdom tooth out, you call the patient home that night.
How you doing?
Jaws numb, no good. You know, typically you're in good shape. So it's a bit of a slower curve. That's why we talked about most likely it's not a money maker.
Right.
But socket preservation and basic GBR techniques, mostly I'm talking about non-flap cases where you can use a membrane and correct fenestrations or dehiscence into the bone is something that I feel like every GP can do and should do.
Yeah.
Because if implants are a part of your treatment option for the patient, if you're not placing them, but you're taking the teeth out, it's a good consideration and good tool to have in your pocket. I don't know, Kyle, you agree with that? Or disagree?
No, I would completely agree on that. I think that's a good place to start. Any bone grafting bigger than socket preservation, I think initially will have a very high complication rate.
Without question.
It just takes a lot. It's not, I mean, it's not an exact science. It is, but every patient is different and every doctor is different.
There's a lot of science.
Yeah, there's just so much science.
There's a lot of science,
You know, what type of bone and what type of blood and what type of tissue and what type of sutures and saliva and bacteria. So I think, like you said, socket preservation is a great place to start for that.
Right. Without question. Agree with that.
And then there's a question, any suggestion on courses?
Kyle's course is a real good one.
I would say take my course with Thomas Linkovicius, not because I teach it, but because he teaches it. If you've seen Thomas speak, he changed everything for me, and so that's what I recommend.
He's quite a smart guy, isn't he?
He's very smart and really like a good sound researcher. You know, like everything that's done is done not to prove anything. What I also love about Thomas is that he's not about any companies. He's just, you know,
this is what I'm doing, this is what's working, this is the science behind it,
you can do it with this company, you can do it with that company, you can do it with that company.
And that's powerful, isn't it?
It's very powerful. Yeah, I really, really like that. And why don't you say a little bit more about your courses?
My courses are local courses. We do a local course every year for about 10 dentists. I'm in the works of creating a platform where dentists can get treatment planning help, where they submit a certain number of data that we have or that we require, and then I can sit there on the computer with them and plan the case completely, not just here's a hole, let's fill it, and then provide support for them to oversee the treatment. That's great.
So it's like a mentoring.
It's a one-on-one mentoring.
Yeah.
So I think because there's so much demand for that where I'm at with all the referring docs, I figured that would be something I can do, but then I'll be able to take that outside of immediate area that I'm working at, hopefully. But that's now that I have time, something I'm working on.
Yeah, you automatically now have a lot more time to do this remote mentoring.
To do projects that were in the back of the brain, and now they're in the forefront.
So make sure you contact Ali. Is there a website or anything for
I'm working on it.
Okay, cool.
So I'll post it on my Instagram stuff. So yeah, follow me on Instagram, please.
So yeah, so they can follow you or message you and find out more about that.
Absolutely.
There's a question: if our primary stability is very low, even 0, what should we do? So my opinion on that is put the implant there. Hopefully you didn't do a punch or it's not an immediate, and you can bury it. More than likely on those type of cases, you'll get very good stability. Now, why is that? When you think about when you place an implant, you get 2 types of stability, right? You get your primary stability, and then you get your secondary stability that happens when biology happens, right? All that primary stability is lost. It all actually necroses over about 6 weeks. So more than likely on those cases, you are going to get good osseointegration. I don't know what you would say. What do you say?
No, I agree. The key is make sure it's not so little that the position in the implant can change, because I've seen that.
Right.
Especially in the aesthetic zone, I've seen the implants are placed some way and the patient comes back and the doc swears that that's not how they placed it. Probably it was just not stable enough in the immediate cases. And you got to make sure that you're not loading those implants, right?
For sure, yeah.
But yes, we're not as worried about them for integration as we were in the past.
Yes.
But you have to really manage the load, and patients have to be very good with it.
Right, yeah. Good, so I think we're out of time, but it was fun. And
Thank you, man. I enjoyed it too.
Yeah, I think that there's a lot of little tips that people could take away from this. So thanks for taking the time.
Maybe we'll do it again sometime. Yeah, man. Thank you as well.
So yeah, hopefully we can do it again. And anybody who's interested, contact Ali about his courses or me about mine. And I'll post this on YouTube, and I'll post this on my Instagram too. So
thank you, bud.
All right. See you guys later.
Stay safe, everybody.
All right. Bye-bye.
Bye-bye.